So this section, we're going to discuss some restrictive lung diseases. So as we've discussed earlier, in restrictive diseases, I want you to think in terms of diseases that limit the lung's capacity to expand, not because of necessarily the alveoli themselves or something in the airways, being the trachea or the bronchi, but some type of somewhat external force. So it can have to do with the connective tissues around the lung, or it can also have to do with extra fluid or air exerting pressure on the tissue itself. So I want you to think about it, restrictive lung diseases in those terms. Now, as we move further, not only to understand restrictive lung disease, but also to start laying a foundation for infective disorders, I just want to review a few cell types so you're familiar with these. I'll expand on this some in lecture. So type 1 endothelial cells are the main structural cells of our lung tissue. So these are the cells that provide basically if you think about building a house, they're the drywall that makes a wall. So they're the cells that make the alveolar tissue, the alveolar sacs, an alveolar sac. Now you have connective tissue, you have collagen and fibrin, elastin, vascular tissue, all of those other things that are, the things that are within the walls, if you will. But the endothelial cells are the main cell structure. So when you think about, and we discuss things that damage lung tissue, primarily that's going to be type 1 endothelial cells. Now, type 2 endothelial cells are the cells that are basically lying in wait. So they are endothelial cells, but they're not fully mature. They're ready to take shape should injury start to happen. We continually go through a process of tissues throughout our bodies dying away and rebuilding. And type 2 endothelial cells are the cells that rebuild. And these get damaged in conditions like emphysema, like we discussed earlier. They don't function as well, so the rebuilding process doesn't happen. And that's just part of the disease process. Now, alveolar macrophages, those are the cells that are the basically first defense. Those are the cells that sit inside the alveolar sacs and function to destroy anything that's seen as foreign or infective or potentially infective, basically anything the body doesn't recognize as body. So macro being big, phage is to eat. Think of like phagocytosis. Those macrophages are literally translated big eaters. So they go in and they gobble up bad things. Think of it that way. Fibroblasts are connective tissues that provide a structure to the cell wall. And there's three components of this. There's fibrin, elastin, and collagen. And they all serve different functions, and they work most optimally when they're in normal balance. So as like most of us, we don't have chronic lung diseases or issues. If you have injury to these tissues, then it changes the composition of the lung tissue. So we'll talk about pulmonary fibrosis, which is an overproduction of fibrin. Fibrin is the really rigid portion of this type of connective tissue. So it's very structural, it's very stiff and firm. It's like the studs, if you went back to the wall analogy, it's like the studs in the wall that give it the firm and rigid structure. Elastin is the portion of the tissue that kind of counterbalances fibrin and gives the tissue to which it connects around fibrin elastic property, just as it sounds. It gives it the capacity to stretch, to expand and collapse, which is what gives our lungs recoil, so that when we exhale, the lung collapses, but it also, or reduces in size is a better description, but also allows it to stretch as we inhale. And collagen is a structural component that helps hold all of that together. The interstitium is the space in the tissue between everything else. So everything that's between the fibroblast, elastin, collagen, and the outer wall of the chest, that's all what we refer to as interstitium. So pulmonary fibrosis is a condition in which there are a variety of potential explanations. There are a variety of precipitating factors. The two predominant ones that are out there today are any kind of lung disease. I mentioned COVID-19 here, but lung diseases, viral infections, if they're severe enough, they're profound enough, those things can stimulate the increase in production of fibrin. And you're going to say, how do we know that's going to happen? And we don't. In some patients it does, in some patients it does not. Not everyone who had COVID-19 got fibrotic lung disease, and not everybody that has the flu or other viruses or other lung infections gets fibrotic lung disease. So there's still a lot to be learned in the field of medicine as it relates to why some people have fibrosis and some don't. And some medications, the one that I kind of want you to be familiar with because you're going to see it a lot, is amiodarone. This is a prominent medication that's used for atrial fibrillation. There's a lot of atrial fibrillation out there. It's also used for ventricular tachyarrhythmias. It's used a lot, both in the hospital and for home management, but it also can precipitate pulmonary fibrosis. So pulmonary fibrosis is essentially a thickening of that rigid connective tissue in the interstitial layers around the alveolar wall. That, again, imagine more studs in the wall makes it more thick. And collagen bundles also form here, which contribute to that thickness. So we have a disproportion of fibrin and collagen to elastin. Remember me saying just a moment ago, they need to stay in balance. So we have this disproportion of fibrin, more of it, more collagen, and less elastin, as opposed to emphysema, which emphysema doesn't have this increased fibrotic tissue. There's not increased fibrin. In fact, we lose fibrin with emphysema. We lose fibrin, we lose collagen with emphysema. We lose elastin. So those tissues in emphysema have nothing to really give them form, shape, and texture. And however, with pulmonary fibrosis, we have too much form, shape, and texture. So it becomes a rigid lung. That's why it's referred to as a restrictive lung disease. And the treatment is going to vary here based on the cause and the severity, how we proceed. And it is a progressive condition and there's no cure. So this picture, it highlights back to the cartoon images I've shown you earlier. So you see here what depicts a normal alveolar or a normal bronchial structure, alveolar structure that has the nice blue open lumen, and it has plenty of connective tissue there around it, the little black fibers that are connected here. And here, emphysema, you can see all of those tissues have gotten destroyed. So what we have left is a very flaccid, poorly functioning alveolus that actually bleeds into other alveoli and becomes quite large. And then fibrosis, you notice the very, very dark and thick lines around the airway here. That is depicting that increased fibrin and collagen around those structures, which make it very rigid, which means that lung is very hard to inflate. And this picture, this image here, you can see the RBC is a red blood cell. The PL is for plasma. So that structure where the red blood cell and the plasma is, that is a capillary. And then over here where it says ALV, that's an alveolus. This connective tissue between the alveoli is so thick that you can't see another alveoli on this slide. You see all of the collagen deposits here, and you see these striations between these two collagen words here. Those striations are fibrin tissues that are laid down there in a linear fashion that, again, you can see with this increased tissue why that would be more rigid and hard. So there are basically these few categories that with which I want you to be familiar. Idiopathic pulmonary fibrosis means this patient has been diagnosed with pulmonary fibrosis and we can't really identify exactly what has caused it. So perhaps it's something that's evolved through their lifetime and now it's severe enough we note it and we can diagnose it, but we can't say, oh, they were exposed to this inhalant or this toxin or this, DDT or some other kind of toxic chemical. And we can say they don't have cystic fibrosis, they don't have sarcoidosis, they haven't had any kind of pneumonitis or radiation exposure or asbestosis. So that's what we mean by idiopathic. It's shown up. It's really the only thing we can see, one of the only things we can see, but we can't explain why this has formed. We have no typical causes. Cystic fibrosis refers to a condition where there is a mutation that causes this to be an inherited disorder that changes the way patients manage their chloride, which changes their salt component, the sodium component in their lung tissue, which ultimately changes the thickness of secretions. So as I've mentioned, cystic fibrosis is one of those conditions that walks the line of both the restrictive and obstructive, because those thick secretions produce an obstruction. But there is a genetic process that increases fibrin production in the lung tissue of these patients. Sarcoidosis is a connective tissue disorder that results in a rigidity of the connective tissue around the body and then impacting the lungs. This can be sarcoidosis can be related to like a rheumatoid arthritis, such as ankylosing spondylitis, which are, it's a rheumatic disorder that is like an arthritis. Well, it is a form of arthritis, but it produces a progressive fusing of bony structures. And as a part of that process, the connective tissues in and around the lungs can also become rigid, stiff, and hyperfibrotic and make them very rigid. Hypersensitivity pneumonitis is an inflammation. Pneumonitis referring to inflammation. Hypersensitive is a sensitivity reaction to some type of chemical, whether it's inhaled or ingested or infused, but the lungs have a reaction in which they have this profound inflammatory response, and that inflammatory response then facilitates and precipitates the formation of these fibrin tissues, which then produces a fibrosis. Radiation fibrosis has to do with patients who have had some type of irradiation. This can be in a large area of the chest, or it could be in a focal area, or it could be from a generalized exposure to radiation if someone worked in an area where there was a high degree of radiation, such as people who may have been at, for example, the Chernobyl nuclear reactor when it had a meltdown many, many years ago. That type of radiation exposure, in addition to causing things like cancer, can also cause things like pulmonary fibrosis, where patients form increased connective tissues around the lungs. And then asbestosis, you're probably familiar with asbestos as an insulation. There are some buildings that still have asbestos in insulation, and being exposed to asbestos and the condition, the lung inflammation process that's caused by asbestos inhalation, which is referred to as asbestosis. Part of that process is a fibrotic process that makes the lungs real stiff, rigid, and non-compliant. So this is just another slide that provides a little more summary on a couple of these. Sarcoidosis is that hypersensitivity response, and granulomas produce this thickening. So The thing about sarcoidosis is that condition is not limited to the lungs, and it can start elsewhere and progress to the lungs, or it can manifest first in the lungs and then progress elsewhere. I've just discussed hypersensitivity pneumonitis, the previous slide being the list, and this kind of being a recap. The drugs and chemical radiation component, I've mentioned amiodarone, and I've mentioned asbestos. You see those listed here. The other drug that I'd like for you to be familiar with that you may see, particularly as patients deal with cancer, is bleomycin. Bleomycin is a chemotherapeutic agent that is prone to causing pulmonary fibrosis in patients. Cystic fibrosis, we've touched on some already, but it is a genetic condition that basically, because of this mutation, it decreases the patient's capacity to transport chloride. And when you do that, you're also affecting sodium, which means you end up with very thick secretions, secretions so thick they can form a plug, sometimes they can feel almost like plastic. They're that rigid. So mucus plugs, and then this process can also contribute to bronchiectasis and inflammation. So all of this increased mucus and the thickness of it, it's difficulty to move it, increases, and that with the bronchiectasis and the inflammation makes them more susceptible to infection. And so now you have, you can see there's a very high risk of complicating conditions here between not only the restrictive lung disease, the obstructive lung disease, infection. So it's a very challenging condition with which to deal. And there's not a way to reverse this genetic process. The key is management, early recognition, and early intervention with drugs that help maintain thin secretions and mobilize secretions and avoid infections, immunizations, all of those things. And you'll get more of this with Miss Dover in her class in pediatrics. Just about any time we suspect pulmonary fibrosis, there's most likely going to need to be some advanced testing. Genetic testing, of course, to diagnose conditions such as cystic fibrosis, but then also biopsies are going to help us identify whether this is more of a pneumonitis, whether it's something that could be secondary to drugs, or a sarcoidosis. So biopsies are going to be our big indicators there. Some classic presentations for pulmonary fibrosis are going to be rapid shallow breathing. Remember, you have a very stiff and rigid lung. Notice this. People confuse pulmonary fibrosis and emphysema all the time, but they're not similar at all. In fact, they're on opposite ends of the continuum. If you recall, when we talked about emphysema, one of the characteristics of that condition is a very long exhale because they retain so much extra air, and sometimes they can have these very long exhalations. These patients don't have that capacity. The lung is too stiff to do that. So they have poor lung compliance. If you try to ventilate these people with an ambu bag, they're very hard to bag. And we try to avoid intubating these patients as a last ditch effort because their stiff, rigid lung makes it difficult for them to come off of ventilatory support. They could have crackles, they could have wheezes, they could have both, they could have neither. So this makes this a little harder to pin down just from using a stethoscope, simply because they may not be able to move enough air to produce a wheeze or a crackle in larger areas. So their blood gases, one of the indicators there is they will have likely a decreased PO2 and an increased PCO2. That's the one similarity they share with emphysema, simply because they can't ventilate and they have a reduced diffusion capacity of CO2. Remember us talking about gases diffusing across an alveolar capillary membrane. If that membrane is thicker, then it is harder to diffuse the gases, so it's hard to get PO2 in and it's hard to get CO2 out. So they can have very low PO2s and they can have very high CO2s, not because they're trapping air, but because they're trapping CO2 and having decreased ventilation. So the other component here is that because the capillary bed is also destroyed is not the best word here. The capillary bed is also restricted by this fibrotic tissue, which can cause increased pulmonary vascular resistance in the vascular bed around the lungs. So that can definitely impair blood flow around the lung tissue, which can subsequently create complications with oxygenation and ventilation, and can also create conditions, compounding conditions such as pulmonary hypertension. On blood gas, their pHs could be normal at rest because they have moved to a place over time to compensate. With exercise, stress, distress, strain, illness, that sort of thing, anything that puts a demand on the respiratory system, early on, you would expect to see a respiratory alkalosis because they're going to be puffing to pant away some of this CO2. And then later, they're going to develop a lactic acidosis. That's typically the way that condition progresses. Now, the way we're going to treat this is by and large with corticosteroids. That's the primary intervention, and that will start early. Notice that bronchodilators are not necessary. We may use bronchodilators, but they aren't necessarily the go-to drugs because the problem is not the airways not wanting to dilate. It's because the structures around them are restricting their capacity to dilate. So corticosteroids are going to be our mechanism to try to mitigate that inflammation and that inflammatory process that's producing it. These patients are going to get oxygen, so that's definitely going to be a component of it. Mucolytics are going to be a profound portion of this, particularly with cystic fibrosis, trying to keep those secretions thin and mobile. Dornase alpha is a drug that is designed for the treatment of cystic fibrosis. It's designed to try to mitigate the fibrotic formation process. Results vary from case to case, so it's not yet become a standard of care in the field of pulmonary fibrosis. And of course, antibiotics are likely going to be a component once there's concerns about infection and that sort of thing. So from a nursing standpoint, we want to provide a clear understanding of the disease process so that people have a realistic grasp of the outcome here and what's expected. Because one of the things I didn't mention before is this may end up in the situation where you're considering lung transplantation. And by making sure patients have a clear understanding of the disease process, this helps patients understand that the way to treat this is going to be to prevent inflammation and irritation of the lungs. So their behaviors are going to be important by perhaps limiting exposures at critical times, avoiding inhaled chemicals, practicing incentive spirometry even when they're not ill to maintain and optimize lung function, the importance of corticosteroids to limit inflammation and mitigate this process, and also to manage expectations down on the bottom, that you need to realize that one, you may be in the place where you're having to entertain lung transplantation, organ transplantation at some point in time. There are spiritual considerations that go along with that in various spiritual disciplines and practices, whether people feel it's appropriate to have other people's lung tissues in their body. And just the whole emotional component of having to have a transplant or maybe not qualifying, and compatibility, of organs and waiting lists and all of the ins and outs that go along with the considerations of transplantation. So there's a lot of education that's a key component of understanding the different management processes here, like managing secretions and exposures and being diligent about steroids and medication regimens, that sort of thing. Now, chest trauma is a completely different form of restrictive lung disease, and we'll cover this in the next video.